It's just gone 6:32, so we might get started. Hi, Belinda. Amazing. Hello, everyone, and welcome to the Eye Health Collaborative Care and Quality Improvement in General Practice webinar. Thanks, everyone, for taking the time out of your night to join us. So I'd like to start with an acknowledgement of country. So Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work in the community takes place. So the Wurundjeri, the Wurrung people, and the Burrung people, and the Wathaurong people. So I'd like to pay my respects to the elders past, present, and emerging, as well as pay my respects to any Aboriginal and Torres Strait Islanders in the session with us today. And also just acknowledge that it's a really challenging and difficult time for our Indigenous and First Nations communities at the moment in light of the recent referendum outcome. Just some housekeeping before we kick off. So please feel free to use the chat icon and put any questions in either the Q&A or the chat box. Here we are, beautiful. So yeah, it's got your chat icon and your Q&A icon. And just also note this session will be recorded and you will receive a link to the recording of this sessions and a copy of the slides. Beautiful. So I'll just introduce our first speaker. So we have Maria Buey from Melbourne Eye Care Clinic. Maria grew up in Sydney and completed her Bachelor of Optometry at the University of New South Wales. She went on to complete a graduate certificate in ocular therapeutics and a Master of Optometry with an interest in child vision. Maria's had a long and varied career in optometry. She's volunteered in multidisciplinary health teams with Vietnam Vision Project and has worked with International Centre for Eye Care Education in teaching activities in Da Nang, Vietnam. Maria has always been passionate about teaching and has previously worked at the UNSW Optometry Clinic. And following a move to Melbourne, commenced working with Melbourne Eye Care Clinic in 2015 as a senior clinical teaching instructor. Over the last 12 months, she's taken on an additional role at the clinic to develop stronger relationships with external partners, including local GPs, schools, pharmacies, and local council. So I'll pass to Maria now to present to you all. Thank you.
Hi, everyone. I'll just get my screen going. All right, so just hopefully you can see that. Emily, just let me know if there's any issues. So as Emily mentioned, I'm an optometrist in the area. I'm in Carlton, and I'm going to talk a little bit about how we can collaborate optometrists with GPs like yourself. And I also would like to thanks Emily for the acknowledgement, and I'll add my acknowledgement of where I am also on the traditional lands of the Wurundjeri people of the Kulin Nation, and I also pay my respects to elders past and present. And kind of in the spirit of collaboration, I think it's really important moving kind of post-referendum to really listen to the voices of Aboriginal and Torres Strait Islander people and elevate them where we can. Tonight, I'll be kind of talking about a little bit about health pathways, which you might have heard about, in particular in relation to eye care, and we'll talk about factors which would prompt referral to primary eye care, and we'll talk a little bit about, so I'm just trying to minimize some of these things here, talk a little bit about kind of red eyes, foreign bodies, eyelid stuff, and also diabetes as areas that collaboration is really important between GPs and eye care practitioners. So I want you to kind of reflect on this scenario, a scenario that you have probably been in before, where a young man comes in with a sore eye, and he tells you he's been kind of doing some projects at home that, you know, involved grinding and metalwork. So you probably know that this person probably has some sort of foreign body in the eye that is contributing to that pain or discomfort. So this actually is a screenshot. You know, you could probably identify many wrong things this person is doing. This is actually from a video of how not to use an angle grinder. If only all of our patients would kind of look into that a little bit more closely. So, if you're going to kind of address something like this in your practice, in your rooms, you really need to think, are you equipped? Do you have what it takes, or what you need, really? Sorry. Um, so things like fluorescein, blue lights, so you can kind of get these kind of handheld blue lights to help really fluoresce the dyes. Do you have kind of foreign body removal tools, which can be relatively simple, so fine tweezers or a 25 gauge needle can really be useful. Cotton buds have its place, which we'll discuss in a second, but maybe not for all foreign bodies. So if we're kind of looking at removing foreign body from the conjunctiva, from the tarsal plate, a few things we kind of need to do to get started. So first, always a good idea to measure the visual acuity, perform your examination, and that's usually got to involve some fluorescein and a blue light. So the fluorescein can really show where there may be a defect that is caused by a foreign body kind of rubbing against the cornea, so from underneath the eyelid, and help kind of really localize the foreign body as well. If you find, and also part of that, obviously doing a lid aversion as well. So that's one place where a cotton bud can be quite useful. But if you find the actual foreign body and it is underneath the lid, you might want to try just a simple saline flush first. So that sometimes it's kind of stuck under there, but once you just push it off with a bit of saline, you can really just kind of push the foreign body off, which might be a simple fix. If you're using, if it doesn't kind of flush off, it's a little bit embedded and you need to use something. This is an instance where maybe a cotton bud can be useful. Make sure you kind of moisten it with the saline slightly, because it will help stick the foreign body to the cotton bud. But tweezers may be more practical, as it is obviously much more precise and actually can lift out something that's slightly embedded as well. And once you're done, you may want to flush again just to make sure like you've caught any other of the small debris, and really make sure everything is gone. In terms of using local anesthetic to numb the eye, I mean, certainly that may be useful if the patient is in so much discomfort and pain that they can't even open their eyes. So obviously having some anesthetic can allow you to examine them. But where the patient is relatively comfortable, they might have a foreign body sensation, but relatively comfortable, you may, and the foreign body you're removing is underneath the eyelid, you may not want to use the anesthetic, because you could get some kind of that instant feedback once you removed it if they're feeling a lot better. Whether if you use anesthetic, you might need to wait about 5 to 10 minutes to see how they're feeling. So I'll kind of refer kind of at different points the community health pathways. So, kind of remembering all those steps, even though you have all the tools, remembering all the steps or the little things that you might need to do before you actually go in and remove. The community health pathways have some really good information about foreign bodies and the eyes. There are a few points that I'm kind of would kind of think about or reflect on. For example, it suggests that using a magnification, like using an ophthalmoscope or a loupe, and I would suggest that for some foreign bodies, particularly ones involving the eyelid or the kind of white part of the eye, it might be okay. But certainly for corneal foreign bodies, which is what we'll talk about next, I would say that you need a little bit more than just magnification. You probably need something like a slit lamp, which allows you to kind of better localize where exactly the foreign body is in the cornea. And we talked about using that cotton bud, again, probably okay for things under the lid or the conjunctiva, but I would avoid it on the cornea. It's much too big, it's not precise enough, and rubbing a cotton bud on the cornea itself can cause a fair large abrasion, which will also need to be managed. I like this line that I saw: if you only attempt if you have an adult that's cooperative, which is very true, and also if you're confident. And I would add to that for a corneal foreign body, and a slit lamp that you know how to use. But if you are removing a corneal foreign body using a slit lamp, again, as before, assess just as before, attempt that saline flush first. And in this case, definitely using some anesthetic. It's really important because otherwise the patient will not be able to cooperate with you kind of touching their cornea. I find like a 25 gauge needle, or they've said it's 20 gauge. I mean, that's fine. You're using kind of the edge of the flatter edge of the needle rather than the pointy tip to kind of scoop it out. And it does suggest you can kind of bend the end, and that certainly helps you hold the 25 gauge needle and kind of gently scoop off the corneal foreign body. Yeah, just remember that these foreign bodies can be very small and difficult to do without magnification and depth perception. If we look at the cornea itself is only about 500 or so microns, and the epithelium, where a lot of foreign bodies are, is only about 10 microns of that. And really, you don't want to be going beyond the epithelium into the stroma, because that's where you will cause scarring, which sometimes is unavoidable, but you really need to kind of consider that especially if you're removing central corneal foreign bodies. And that's where collaborating or coordinating with primary eye care providers like optometrists can be really useful. All optometrists will have a slit lamp as standard, but I would also confirm to see if they actually have the tools to remove a corneal foreign body, because we don't want to be sending patients where they can't receive the treatment they need. But the other thing that is really important if a patient presents to you with this kind of problem is looking for red flags or those warning signs of much more serious conditions. So the first image on the left there is a picture of we can see the pupil is not circular, it's more peaked, so it's pointing upwards. And this happens when there is a penetrating foreign body. So a foreign body has gone completely through the cornea and entered into the eye itself. And that causes the iris to kind of almost, from the pressure differential, almost be pushing out towards that entry point, and that's where you get that peaked pupil. So if you see any signs of a penetrating eye injury, that's definitely more kind of urgent, requiring hospital and ophthalmology consult to kind of address that. Similarly, the second one is another sign of penetrating eye injury. It's called sidal sign, and that's where when you put the fluorescein on, so the fluorescein will cause the tears to fluoresce, and under that blue light, the tears will appear like this greenish hue. When you have sidal sign, what's happening is aqueous from inside the eye is pushing out through the entry point or through where the foreign body has gone completely through, and it pushes the fluorescein to the side. So then you see this dark river. That's a positive sidal sign, and again needs urgent, probably hospital care. And the third one there is a hyphema. So if they've had a more serious injury that may have involved a foreign body, but also kind of significant blunt trauma, you'll get blood in the anterior segment of the eye. So this is not blood on the white part of the eye. This is blood in the anterior chamber, so blood kind of in front of the iris. Again, probably requiring an ophthalmologist care, maybe not as urgent as the penetrating eye injury. Depends on how big the hyphema is. The bigger it is, the more urgent it becomes, because the more likely it is to cause permanent vision loss and other eye problems. And the last one there is, again, something to be conscious of, but not nearly as urgent as those other kind of three images. You probably recognize this as a rust ring. So sometimes if there's metal foreign body, it will cause rust. And rust can be quite toxic to the eye, so it's quite important to remove that. So again, particularly if they're a bit more peripheral, if you feel confident, you have a slit lamp and you have the tools, you can kind of slowly dig that out with a kind of a needle tip as well. But what is much more effective, it tends to be kind of a burr that you can use to kind of push it out much more quickly, which sometimes the patient would prefer. So again, if you have that, even if you try to remove it, it doesn't quite remove completely, sending to a local optometrist who has a burr can be quite useful, or your ophthalmologist if they have the time to squeeze a patient in, and again, if they have a burr. But once if you don't have those kind of more serious conditions present, once you're done, there's a few other things to do. So you need to think about pain relief. So obviously the process of removing particularly a corneal foreign body can be fairly painful and will leave an abrasion that will cause discomfort. And sometimes, although it might have been a foreign body underneath the eyelid, but it's caused a bit of minor corneal trauma, so the patient will still feel some discomfort as well. So managing that. Just checking again, this is a little bit from the history. So if they tell you, they've been, I don't know, in a car accident, or a ball hit their face, or a bird hit their eye. So just looking for those other signs of ocular trauma, it's important to screen people for that. And think about the risk of infection. So if the corneal defect left behind after removing a foreign body is sizable, then you'll need to have some sort of antibiotic cover. And it will depend a little bit on the material that went in there in the first place as to what kind of antibiotic cover or antimicrobial cover you might consider giving. And it may be different if they're a contact lens wearer as well, because they tend to have different kind of a slightly different microbial biome on their eye. Some traditionally, you might think about patching the eye to kind of help with the pain, but the evidence suggests that it's not very useful for improving pain or improving healing, and it can kind of get in the way of actually getting those important antibiotic drops in. So generally, we don't suggest you patch the eye where it has had a corneal foreign body, sorry. What can be useful is a bandage contact lens, so that can act as a barrier between the lid and the eye, which is much more comfortable. You can use drops while wearing a bandage contact lens as well, and obviously the contact lens itself is clear, so the person can still see through that eye, and you can see the eye as well, which is very useful for follow-up. And if the actual defect is really small, like less than a mil, you might even just do like a thick eye ointment, very regularly for that first 24 hours, in which case the wound should have healed or closed up by then. So I think when we're considering foreign body, it's a kind of scenario where, the GP, the primary eye care provider, the optometrist and ophthalmologist all have a different role to play, and it's probably kind of in a staged way. So the GP can do that more superficial foreign bodies, can screen for more serious things, optom doing perhaps more embedded foreign bodies, and when there's serious eye injury, the ophthalmology needs to kind of be involved there. And we should all be reminding our patients that often these eye injuries are preventable, and they should be using correct eye protection or face protection, depending on what they're doing. I'm going to jump over now to kind of the red eye. And red eyes, you probably, again, have seen a lot of red eyes come through your door, and sometimes it could be, something pretty self-limiting, like a bacterial conjunctivitis, or it could be sight-threatening, like a uveitis. And it's quite hard to tell the difference just by looking at the patient, and even just by a history. It's not always obvious. So I'll just give
Maria,
you this. Sorry. Yes.
Sorry, can I just interrupt you for just a second? We just had a few questions come through just about the topic that we were just covering.
Sure.
So Stefan just wants to know, is it a single or a double pad?
I would say that you wouldn't do either of those. We don't tend to do it in optometry because we tend to use things like bandage contact lenses. Mostly the issue with the pad is that it can create an environment where bacteria are more likely to grow. And also you can't keep, like the person can't see their eye, so they can't tell if it's getting more red or developing more discharge, or they can't tell if their vision's getting worse because their eye is covered. So that's kind of the issue with using a pad. So I generally wouldn't recommend an eye patch.
Beautiful,
Or an iPad,
thank
sorry.
you. And we had another question, is Band-Aid contact lens okay to use with antibiotics?
Yes, so you can, and that's one of the benefits, is that you can be using antibiotics while you're wearing the contact lens. So, typically for kind of more vision use, we typically don't recommend you use a contact lens to sleep overnight, and we typically don't recommend using kind of medicated eye drops with contact lenses, but this is a more therapeutic purpose, in which case the benefits of using the contact lens overnight and with the eye drops or the antibiotic eye drops is the benefits of that far outweigh the risk involved.
We had one final question. When can they wear contact lens for short-sightedness?
Can they wear contact lens for short? So yeah, so if the person is already a contact lens wearer, they can just, it depends on the contact lens. So some contact lenses are okay for use as a bandage and some are not. And it's to do with the amount of oxygen that is transmittable through the material of that contact lens. And not, so the answer is it depends on the specific contact lens they're using.
Thank you.
Yeah, no worries. Thanks for your questions, guys. So this is a scenario where, again, a person might come in, they say that their eye's been irritated or a little bit uncomfortable for the last few days. You look at it, it does look a bit red. You put some dyes in and you have a bit of a look. You see there, you use your blue light, you use your fluorescein, you see there's something there on the cornea, so you know that there's something that is causing that discomfort, and you're able to have an even closer look with your magnification system. You see this small corneal defect, and it's pretty non-specific. It's a bit of a blodge on the cornea, as using technical language. But what do you have to decide to do something, because you can see there's something there, but what do? Do you give an antibiotic? Do you give a lubricant? Because it's small, should it just get better on its own? And this is the difficulty with trying to kind of manage these conditions, because sometimes it may not look like much, but it could be quite serious. So this is kind of the reality. So this was a patient that we had, but this is what the textbook tells us it looks like. So this is a herpetic lesion. It doesn't always look like that obvious dendritic branching kind of lesion that we expect. And so, many things that you might try with this, it may not be necessarily harmful unless you go for a steroid, which really might kind of enhance the situation perhaps, or in a detrimental way. But obviously the more timely our interventions are, the better. And so this is where, again, the optometrist can coordinate with the GP and make sure that patients are receiving good care. The issue is not just, even if you suspect it's herpetic and you give antivirals and oral or topical, the problem with herpetic eye disease is that there are some other eye conditions we need to look for in relation to the herpes. And if treated poorly, can result in corneal scarring. The other things we need to be looking for is, do they have also elevated eye pressure? Do they have any iritis associated with it? Or do they have any uveitis internally associated with it? Because those will need kind of additional treatment on top of the antivirals. So looking at herpetic eye disease and herpetic disease generally is obviously, you guys probably know more about it than I do in a way, but the eye condition itself can be quite complicated. And I think, between the optometrist and the GP and the ophthalmologist, we all have our different roles that can be happening concurrently or kind of in a staged way. It might be the GP suspects it, sends it to the ophthalmologist gets everything under control, sends it back to the optometrist to kind of do that monitoring for recurrent disease, and might even give the optometrist a plan. Okay, if it recurs, do this. It might be a more simple case that the optometrist and the GP coordinate together. The GP may be helping with the prescription of orals, while the optom checks for, things like pressure spikes and uveitis. So I think it's a condition where not one of these professions can really manage it on their own, the short and long-term problems associated with herpetic eye disease, but where we all probably have a bit of a role to play. And again, I've put in links there to health pathways. Again, because sometimes it could be, you might have a good suspicion that it is herpetic, but you're not quite sure what to do and what time frame you need to do it in. Looking at health pathways can be quite useful. Health pathways often refers to non-urgent where it says non-urgent ophthalmological assessment. You may also be considering optometrists there as well, particularly if it is more non-urgent. So talking about what does the optometrist, what can they actually do? I mean, it's changed a lot over the last 20 to 30 years. Optometrists now can manage a lot of these red eye, anterior eye conditions. And there are some caveats though, obviously. Firstly, the optometrist needs to have an ocular therapeutic endorsement to the registration. So all optometrists graduating probably in the last 5 to 10 years have this automatically as part of their training. But obviously optometrists who graduated before that needed to do additional training. So not all optometrists have this, but about close to 3/4 of optometrists have this endorsement now, and which means they can prescribe topical antibiotics or steroids or ocular therapeutics. But obviously, optometrists work best as that primary eye care, as that first line, and they still need to be looking out for when they need to refer to, for example, ophthalmology for more severe or non-responsive cases, or back to GPs for like perhaps oral treatment or systemic investigation if that's indicated. So I'll jump over to kind of eyelids now. It's kind of related to therapeutics a little bit. And again, I mean, this actually, I've written here young child, but it could be a teenager, could be adults as well. But probably in terms of eye problems in kids, this is one of the more common ones. And a swollen eyelid can be caused by a number of things, insect bites, allergies, infections. And again, looking at health pathways can help kind of looking at that information there can really help you kind of ask the right questions or consider the right things to kind of come up with a likely diagnosis. I'm going to focus specifically on styes, preseptal cellulitis and orbital cellulitis, and looking at how in your rooms can you help distinguish these three things, because these two things I think sometimes can look more similar. So a stye, like particularly a very like large or acute stye, and a more mild preseptal cellulitis can almost look the same. So just a refresher, a stye is an infection of a gland within the eyelid. Preseptal cellulitis is an infection of the tissues anterior to the orbital septum, so that's kind of the eyelid and the skin around the eye. And orbital cellulitis is when the infection has reached into the entire eye socket. So styes and preseptal cellulitis can be tricky to differentiate. A tip that I give optometry students here is kind of making sure you kind of really press along the eyelid. So sometimes you'll see a specific lump. If you press that lump, yep, the patients who say, oh, yep, that's a bit sore. The whole eyelid might be inflamed. But if you press on other parts where the eyelid is inflamed, but there's no infection, they'll say, oh, no, that feels fine. So the pain associated with the stye is much more local. If you do the same thing in someone who has preseptal cellulitis, anywhere you press along the lid should give that same pain response. Yep, it's sore there, it's sore there, it's sore there. Whereas the stye is, oh, no, it's just sore there. It feels fine when I press over there, even though the whole lid might look red. And treatments for both can be pretty conservative. I would, in terms of preseptal cellulitis, I would be leaning more toward doing the antibiotic side, just because there is some risk of it becoming orbital. Particularly if they have other symptoms, so if they kind of have a mild fever or if they're immunocompromised, I would certainly be considering more therapy. In styes, it's really a little bit dependent on how comfortable are they, and sometimes people, if anything, it's more because they're worried about the cosmesis of the stye and they have some event, then you might think, okay, well, maybe let's give it an antibiotic to kind of hasten the likely resolution. Orbital cellulitis will be fairly different in that generally the presentation will be more severe. So more swelling that's broader across the face. They will present in more pain. They may have double vision because their eye movements are restricted, and they will generally be unwell and have fever. And it's really important to distinguish these patients because they really need emergency care, probably IV antibiotics, because there is some site and even life-threatening things that can happen with orbital cellulitis. So hopefully that's kind of a quick little thing of how to distinguish those types of infections in the eye, in and around the eye. So, sometimes people come in and they say, oh, I have this new bump on my eye, or I'm not sure about this, or it's been there a while, but I'm not so sure about it. And so there are many kind of eyelid conditions that are benign that can be cysts arising from the eyelid glands or from the skin around the eyelid. So we have here, we have this, the top right one, in case you can't see my arrow, is the kind of the lasma, that kind of fatty deposit underneath the eyelid, very common as you get older. It could be something like a papilloma underneath that. And at the bottom here, we have like an inclusion cyst. Again, perhaps the person wants to have it removed because of chemesis, but not really concerning. And we have a few other things like molluscum at the top left there. So all of these are kind of benign, but I guess really the question is, there are so many types of these types of lumps and bumps. How do you distinguish? So kind of, really looking out for the warning signs. And I suppose more important than knowing exactly what you're looking at is kind of picking up on the warning signs. So here are some pictures. These are just pictures of some malignant things, so basal cell carcinoma, squamous cell carcinoma, and some pre-malignant things like actinic keratosis down here, I believe. But what you're looking for is a lesion that is just getting larger gradually, and it's relatively painless, and sometimes photography can help. And obviously these days we probably have more opportunity to look at photos because everybody has a photo on a camera on their phone. but also looking at if the lesion is also is prone to ulceration and non-healing. If there's any bleeding, so that's not normal for a benign lid lesion. If it's distorting or destroying the eyelid margin, and associated that if there's any loss of lashes, like in this top picture here. So even this one looks kind of quiet, it's kind of white, not that red, but you have a loss of lashes along here, which is a concerning sign. If there's any kind of new blood vessels growing in there, if it looks thickened, or if it's you see a lesion and the person keeps getting a bit of a red eye associated, that kind of comes and go a lot, that could be a sign that it's a more malignant lesion on that lid that's kind of contributing to kind of ongoing inflammation of the eye. And other things to consider is obviously history of skin malignancy, or if they're immunosuppressed, are perhaps more likely to have these more malignant lid lesions. And so obviously anything of concern should be kind of investigated further, biopsy, maybe referred to an ocular oncologist for further advice. But rather than learning each, for me, I find that rather than learning each particular problematic lid lesion is looking at the kind of warning signs. So we talked a lot about the front of the eye, so I'm going to kind of jump to something completely different now and talk a little bit more about the back of the eye. So, you probably have many patients with diabetes, and this is taken from a real case. So this is a patient who's had young, but is type 1 diabetic of more than 20 years, had some improvements in their glycemic control over the last year, and doesn't really have any vision problems, doesn't really have any complaints. Vision's pretty good if you happen to measure the acuity. So something to think about is, asking, amongst other things, is when did they last have an eye exam, and how often should they be having an eye exam? And again, Health Pathways helps you look at their kind of doing a quick risk assessment and then kind of matching the frequency of eye exams in relation to that. But this actually is a patient of ours, so we did examine them. They did come in for an eye screening. I've put a warning sign there on the kind of the length, although things look pretty good, the length of time they've had the diabetes is a bit of a warning sign. This is a retinal photo, so diabetes affects the small blood vessels in the body, including the eye. And looking at this, you might have a retinal camera actually that you might be using for screening. Can't see too much. There's a few spots here and there, like a few little hemorrhages here and there, but not too many. But the advantage of seeing an optometrist and having a dilation is to have a much wider field. This is the same eye, actually, the right eye. And we could see, hopefully you can see there's many more hemorrhages in that periphery to mid-periphery zone, and certainly classifying more as a severe non-proliferative at least. And, if we zoom in on a certain area, we can see actually there are new blood vessels growing, which categorizes this person as having proliferative diabetic eye disease, which is sight-threatening and requires pretty urgent treatment. So if anything you take away from that is just considering the risk factors. So probably the biggest risk factor for the development of diabetic retinopathy is the duration of diabetes. And this is true for type 1s and type 2 diabetic patients with type 1 or type 2 diabetes. And really, once you get to that 20-year period, there's more than half, close to 80% of people have some level of retinopathy, certainly lower levels of sight-threatening retinopathy, but they definitely need to be monitored more regularly the longer they've had diabetes for. So, if we think back to that little case I presented, that patient actually had improved glycemic control over the last year. To how come they have such severe disease? I mean, it's like I said, it's probably mostly related to the length of time they've had diabetes. But actually, if people have intense diabetic management and have a quick improvement in their glycemic control, this is actually a risk factor for worsening diabetic eye disease in the short term. In the long term, it reduces their risk, but for a short period, they're at an increased risk of worsening diabetic eye disease. And other risk factors are things like having high blood pressure, being pregnant, or having had recent cataract surgery. Another case here, similar kind of demographic, so young person with almost 20 years diabetes. In this time you measure the acuity and there's a big difference. So I'll just quickly refresh your memory about acuity. 6.6 is what we consider like average for most people. The second number, the biggest second number, the worse the vision is. So 690 means that he's gotten a lot worse compared to the same time last year. That's a big change in 1 year. And if you happen to have a retinal photo, you see this. So this one is more obvious. Straight away, you see all these red spots and this lipid leaking. So definitely a lot of diabetic disease in the center, which is causing the reduced vision. The great thing with optometry now is that we have access to OCT, or optical coherence tomography, which gives us cross-sectional views of the macula. And most optometry practice, I would say, particularly Melbourne, but even regionally, has access to this. It's very easy to take this type of image, and we can quickly see the difference. So the first one was a normal macula. That's what it should look like. This was what it would look like if a person had macular edema. So a lot of dark spaces where there's fluid filling the macula. We have some other fancy technology, which I won't really go into. But what we should keep in mind is that diabetic retinopathy for younger people is the leading cause of irreversible vision loss. But it's really important that these patients get screened regularly, because we can detect it very early, and we have very good treatments with our ophthalmologists to treat it as well. And I'll touch on this slide because it's important. And this is really a point where GPs and optometrists and ophthalmologists should be working together, because we know that people with type 2 diabetes who have diabetic retinopathy may benefit from being put on an additional medication called fenofibrate. You probably heard of this, mostly used in the treatment of hypertriglyceridemia. Oh, that's a big word. So it's a lipid modifying drug, but it has been shown to reduce the risk of diabetic eye disease getting worse in people with type 2 diabetes who already have some level of diabetic retinopathy. So we need to be optometrists need to be communicating with GPs to let them know that their patients do have diabetic eye disease, and GPs can be kind of communicating with us as to what kind of medications they're on, and if they think they would benefit from this this type of treatment, in addition to obviously management of the diabetes. I'll skip over this. And, suffice to say that diabetic disease, and particularly eye disease, it's really collaborative in the sense that we all have different roles to play. Community screening of diabetic eye disease should be happening with optometry, and we use tertiary eye care for the patients who really need kind of treatment for those sight-threatening conditions. And GPs are really critical in kind of communicating with us what they know about the patient risk factors, reminding the patients to have eye exams, and obviously coordinating with other health professionals for other aspects of the diabetic care. So a person with diabetes can interact with lots of different health professionals. The GP, I think, I did this and I kind of rethought it. I think it's very fair to kind of put the GP, have so much responsibility. There should be more arrows with all the different professions talking to each other, but my skills on PowerPoint are not that good, but you get that idea. So that just brings me to health pathways, and hopefully you've had a look at this. So I learned about health pathways through Emily and her team, and I think it's really great. I mean, as a GP, it's designed and written for primary care consultations. It provides clinicians with a single website to access heaps of information about clinical and referral pathways and resources at the point of care. So you could be using this while the patient is there. It's easy to use, so you just search what you're looking for. So, irritated dry red eye, or eyelid swelling, or foreign body. And it's really a one-stop shop. It allows people to navigate actually a very complex medical system. And particularly if you're new to the area, or you're just unfamiliar with local referral options. And there's also, I should point out, GP-only direct hospital contact numbers. And that sounds very useful. Not so much for me, but for you. And you also get information sheets that can be useful for patients too. And the health pathways was written by GPs with support from local GPs, allied health, and other subject matter experts. And it really enhances clinical knowledge and promotes best practice, and aims to reduce kind of variation in care, and provides you with information on local services available to your patient as well. Very easy. I mean, I registered, and it was very simple. If you head over to, there's a QR code there for you there, but you go to melbourne.healthpathways.org.au otherwise, and yeah, very simple to register and obviously free. You know, lots of stuff about eyes. I mean, for me, actually, I think I'll be using it more to look at non-eye conditions as well, because our patients often present with things that I don't really know much about and I may need to interact with. So I'll be definitely talking to my colleagues about using this like fantastic and obviously free service. So great. I'll just jump to my summary. So obviously we all have kind of clear roles that are kind of interlinked and certainly overlapping, and optometrists are really key in providing primary eye care in the community. You could go to the Optometry Australia website and find an optometrist just by proximity to where you are, but also by language, if they have ocular therapeutics, if they have, like, you could search by all kinds of things, so you can really make it specific to what your patient needs. But in order to kind of achieve really good outcomes, I think communication is really key. Health pathways, I said I won't go into that because I really endorse the health pathway. I think it's a great resource. When you're doing foreign bodies, just think, are you prepared for the before, during, and after? It's okay if you're not. If you're not, can you work with your local optometrist to get a good outcome for your patient? Red eyes, put broadly, it can be quite simple, but the wrong treatment can also worsen outcomes. So really think about that when you're interacting with your patients. So to keep it really simple with eyelid lesions, if it's growing, bleeding, not healing, if it keeps recurring, and if there are lash or lid changes, probably needs further investigation. Diabetic eye disease, I really want to hit the point that early and accurate diagnosis allows patients to access really effective treatments now. And so from your perspective, maybe assessing risk factors for eye disease and working with local optometrists and communicating with them to ensure regular screening occurs. I've also put in a website for KeepSight, which is a website where patients can register their details to receive regular reminders about getting their eyes checked in relation to diabetes. I've covered a lot of things today. Hopefully it wasn't too much of a whirlwind of information, but certainly if you have any follow-up questions, send me an email. I work at a clinic located in Carlton, associated with the university. So you can come visit us or, contact us if you want to have any queries afterwards. Thanks so much, though.
Thanks so much, Maria. I've got a few questions in the chat, if that's okay, if I can pick your brain now. We've got one that says,
I'm gonna do this, and I'm going to stop this so I can see people now. Yeah, okay, great.
You're right. So should GPs refer pediatric eye conditions for treatment?
Yes. So I think yes. So I would caveat that with saying not all optometrists are trained to assess children, but not all optometrists in practice are comfortable seeing children. So I would say, make sure that where you're sending your patient is comfortable. If you use that kind of find optometrist function, you can filter by works with pediatrics as well. So that will make sure that your referral makes sense for your patient.
Beautiful. And we had another question. Do optometrists prescribe lipids?
Sorry, optometrists prescribe?
Sorry, Lipidil?
Lipidil, no. So that's where collaboration is really important. So that's obviously an oral medication. Optometrists cannot prescribe oral medications, only like eye drops. So this is where optometrists communicating with GPs is really important, because we can say, look, your patient might benefit from that, and we would rely on your expertise to kind of decide whether it's actually appropriate in the whole kind of the context of their medical care. But obviously it requires really good communication to know that it's something that your patient may benefit from if they have type 2 diabetes and diabetic retinopathy.
Beautiful. Thank you so much.
No worries. Thanks.
If anyone has any more questions as well, and I do see that there are a few more in the chat, but we can come back to questions at the end of the session as well. Beautiful. So I'll just share our screens for the next presenters. Amazing. Awesome. So we have two amazing speakers here today from Premier Health Partners. So we've got Dr. Paul O'Keefe and Nurse Belinda Bradfield. So Premier Health Partners have been involved in the Enhancing Preventative Eye Health Care in Primary Care Quality Improvement project this year. And as a part of being in that project, they have developed 4 PDSA cycles that they're going to talk about today. So PDSA cycles standing for Plan, Do, Study, Act, which is just a quality improvement methodological framework that we use in general practice. So I will pass over to Belinda and Paul to speak through this slide.
Thanks so much for the introduction, Emily. So we've been involved in this project for the duration of this year. And just some background on our clinic. We're located in the west side of Melbourne, just on the border of the CBD. We're probably a smallish GP clinic. We've got roughly between 3 to 4 GPs, 2 osteos, a exercise physiologist, 2 nurses, and about 4 reception staff. So eye health is something that a couple of our GPs have a strong interest in. So when this project came up, we thought it would be great to upskill all of us really and get the whole team on board. So part of the project meant we had to come up with 4 PDSA cycles. So I'm going to speak about 3 of those today, and just some pros and some cons or some challenges that we found along the way. So the first one is our newsletter and our social media sites. So we put a blurb together about eye health with some links just to get out to our patients what the study was and how our clinic was involved, and just stressing the importance to them of regular eye health. So the positive was that we could reach a large number of our patients by circulating the newsletter. But in the analysing section, we found that it was actually really difficult for us to gauge and get a number on how many patients actually read the newsletter blog, or how many of those patients actually went and saw an optometrist because of the blog. So in terms of data collection, that was a real struggle point for us in terms of our first PDSA cycle. The second PDSA cycle we did was opportunistic screening. So this was obviously largely came down to our GPs. If they had a patient that came in that was in one of our high risk factors, and it kind of ties on to our next PDSA, which was our we did PenCat searches for some eligible patients. So we kind of, I guess, focused on 2 cohorts of patients, our patients over 40 with diabetes and with some certain cardiovascular diseases. And then we also looked at our pediatric cohort of patients. So that cohort, the 4, 5, 6-year-olds that, especially during that COVID period, might have missed out on that before school or their first year of school, that eye checkup that they should do. And obviously during COVID, we know that a lot of children were exposed to probably more screen time than they previously would have been. So we really wanted to try and capture these 2 cohorts of patients. So Paul and myself had that conversation with the GPs, and if they had any of these patients that fell into either of these cohorts, we were just asking them to have that conversation at the end of their consultation about, have they had any problems with their eyes, when was their last eye health check, and if they hadn't had one recently, it was giving them the information of if they needed to go and see an optometrist to go and do that. The pros of this were that we were able to reach quite a few, obviously, patients, and it was quite easy for us to track. Our reception staff had a log sheet at the desk, so they were able to keep track of if that conversation had happened. The GPs obviously had a log chart in their rooms as well, so all they needed to do was write down the patient details for us, and then that fell back to me to follow those patients up. The negative was that we had one of our full-time GPs have to relocate during the year due to family issues. And so obviously we had a bit of a gap there while we filled that position. And then we did have a few challenges with the oncoming GP, obviously in terms of the workload that they initially came onto was quite full. So they didn't have that opportunity to have those conversations with patients. And obviously that just that affected our data in terms of how many patients then that we were having that opportunistic screening conversation with. And then our third PDSA cycle that we did was the PenCat eligible patients. So I touched on it before, and that was where I just put in some data. So for us, we did the diabetic patients over 40 with a cardiovascular disease. And that gave us a whole list of patients. And then between the two nurses, we would contact those patients, have that conversation with them about whether they've had a recent eye health check, if they've been having any problems with their eyes. And we did find that there was a large cohort of them that on the back of the COVID lockdown period hadn't had their regular eye health checkups with their optometrist. Some were nearly three years since their last one. So it was really good to be able to reach those patients that probably would have slipped through the system had we not reached out to them. I guess the negative or the challenge that we found with that was that it was just quite time consuming for us to reach out to patients. We did think about sending out a letter or a text, but we found that a lot of these patients were in that cohort that just respond better to a phone call and that personal touch from the clinic. So we went with doing the phone calls, and we did get through them. There was over 150, 200 patients for us to contact. But again, we had a really positive outcome from the number of patients we could reach and capture. Paul's on the link as well. So I was just going to see if you've got anything else that you wanted to add in terms of our PDSA cycles, Paul.
Yeah. Can you hear me there? Yep. Oh, great. I don't know if you can see me at all. So I just had a late patient book in. So, yeah, just further to what Belinda said, she basically covered virtually everything. Being the business owner, I could probably quickly just chat about the resource allocation was quite a bit for the project, but with some funding, that made it certainly worthwhile doing. But now, from a clinical point of view, absolutely well worth doing everything. That we haven't done a proper cost-benefit analysis, but there's no doubt that a heap more people have had their eyes checked than would have otherwise. But yeah, there's a fair bit of work that went into it. Linda put a lot of time and effort into it. So yeah, from a business point of view, yeah, definitely there's a fair degree of cost, but you know, as I said, with the funding, that sort of that made up for that. So but otherwise, that's about it, really. I think Linda's covered us off pretty fully. So yeah, that's about it.
Thank you, Paul. Thanks so much. Thank you both for sharing as well. That was really excellent. And I'll be sharing some quality improvement activities that will be available for everyone to download at the end of the session tonight. And so just to let everyone know, those QI activities were based and developed off the QI activities that have been tested throughout this project. So those will be available for download very shortly. But thank you both for sharing. That was excellent. So I'll introduce our next speaker as well. So we have Sarah Zabib, the Manager of Education and Development at Vision 2020 Australia. So Sarah is responsible for education and development activities at Vision 2020 Australia, the peak body for eye health and vision care in Australia. Sarah has been working in the non-for-profit sector in Australia and the UK for over 18 years. She has experience in project management, health promotion, and professional education. Sarah is a mother of two who enjoys spending time with her family and traveling, born and raised in France, and she is a committee member of the French Bilingual Association of Melbourne. So I will pass over to Sarah. Thank you.
Good evening, everyone. Thank you very much for the introduction, Emily. I hope everybody can hear me okay. I will start my presentation, which I hope you will find as a nice complementary information to the really interesting content that we've had tonight. So I will share my screen. Here we go. And hopefully it all works okay. So tonight, I just want to give you a brief overview of some of the online learning activities and resources that are available to you all for free. So I work for Vision 2020 Australia. We are the big body in Australia for eye health and vision care. So we basically represent 50 member organizations, some of which you will have heard of. They are Vision Australia, Guide Dogs, but it also includes Optometry Australia, the Australian College of Optometry, and many other organizations who work in the eye health and vision care sector. And basically, we all work together to ensure that we have a common voice, and eye health remains a priority for federal and state governments. And our vision is to eliminate preventable blindness and visual loss, and ensure the full participation of people who are blind or have low vision in the community. So that's the little bit of intro about our organization. Now, as part of the work that we do, one element is we have put in place a online learning platform on which we now have a number of courses that are available for health professional working in Victoria. If you're interested in getting access to the platform, you just need to send us an email at education@vision2020australia.org.au. The image on my slide is the homepage of the platform. And I am just going to give you a really brief tour. So when you access the platform, you will get a list of the courses that you've been enrolled in, a list of the courses available. Available also on this platform is a recording of the webinars that we hosted this year. I will provide you a little list of the topics later on this year, but as part of the pilot project that we worked on with PHNs across Victoria, this year we ran a number of eye health webinars, especially tailored for GPs on a number of topics, and all the recordings are available through the platform for free. When you access the platform, you also have, a help desk or a little bit of help information, and then you can adjust your profile as well. All the information that is collected upon registrations, which only take a minute or two to complete, it's all done so that we can manage your access to the platform, and then for evaluation and reporting, which is aggregated data, so everything remains anonymous in case you wonder. So in my training, we currently have 4 courses that are available on our platform. An introduction to eye health and vision care, and advanced eye care training for primary and allied health. So these 2 modules are quite broad topics, and they're mostly tailored, I would say, for practice nurses or other members of staff who are working in the practice. And they are a basic introduction to eye health and some of the main eye conditions that could lead to blindness if they were not picked up and managed early on. So it has information on, for example, glaucoma, age-related macular degeneration, diabetic retinopathy, and it has also a little bit more information around refractive error, so short-sightedness, long-sightedness, this type of eye conditions. We then have a course which is called Diabetes and Eye Health, and that is specifically focused on the conditions that can affect the eyes of patients who are living with diabetes. This course is tailored for diabetes educators, but anyone in general practice are invited to take this course as well. And we also have common eye conditions. So this course is more tailored for GPs and is also a broad introduction to eye health, also touching on some of the main eye conditions, but with a little bit deeper knowledge on it. So all of these courses have been created to kind of like give all health professionals and allied health professionals a good basic information around eye health. We also have a couple of courses coming in the future, which will be on ocular emergencies and on children's vision. They'll be coming in the next month or so. And also common eye condition is accredited by RSCGP. Now, next slide. So I was pointing out earlier to the training catalog. So that's the where you can find the list. And so basically to access the platform, you just need to either contact us or your PHN. We will send you a link, and then you can self-enroll in the platform, and it's all free for health professionals working in Victoria, and then you can just enroll in the courses that you are interested in. I mentioned webinars earlier. So this year we hosted 5 live webinars, and then we also had one recording only webinar. And so the topics that we had were glaucoma, age-related macular degenerations, diabetes and eye health, children's vision, ocular emergencies, and cataracts. They were 1 hour each. And they include question and answers, and also a little bit of information around health pathways. Each time there is a keynote speaker on the topic. This year, they were all presentations by ophthalmologists, and then we had each time we had about 10 minutes of presentation by someone from health pathways. So if you're interested in watching them, again, you just need to ask us for access to the platform. And then you will also find, so these are not on the platform, they're sitting on another website. If you have a look at visioninitiative.org.au, we produced a broad range of patient information sheets on the main eye conditions that could lead to vision loss in people aged over 40, and then a few other topics such as smoking and eye health, or low vision services available. And all of those are available in English as well as 10 other languages. So you can just click on them, print them, use them with your patients. There's also audio recordings if you have patients who are not able to access the print copies. And then there is also on the website, I think it's 10 videos as well that complement the key messages, and the key messages that are in those information sheets. And basically the videos are a very brief explanation of what happens during an eye test, what sort of tests are being carried out, and why it is important to have an eye test, and where to find more information. So again, they're available in English and many other languages, and some of your patients might find them really helpful. And then there is a whole lot of other websites that you're more than welcome to go and visit. So I would encourage you to go and have a look at the website of Optometry Australia and the Royal Australian and New Zealand College of Ophthalmology. On both of their websites, you will find specific information for GPs. So some of them are guidelines, collaboration guidelines, information specifically drafted for GPs. I think Optometry Australia might also have some template referral letters, I think. The Australian College of Optometry is a key service across Victoria. They provide the Victorian Eye Care Scheme, which is for people on low income and pension cards, and so you will find plenty of information about their services on their website. I highly encourage you to go and make sure you are aware of their services. And then the Royal Victorian Eye and Ear Hospital also has a specific section on their website, which is for GPs, which has a lot of information, a lot of resources. There is also access on many webinars and other trainings that they have organized. So it's a good point of information at all. A few other source of information, Victorian Aboriginal Community Control Health Organisation has got a page where you can find brochures that you can print, and they have been specifically designed for patients of Aboriginal and Torres Strait Islander descent. There is also a training available for Aboriginal health workers and practitioners that can be, I think you need to request access through VACHO. And then there is also a whole range of resources on the website of the Indigenous Eye Health Unit, which are specifically resources tailored for Aboriginal communities on specific topic. They have quite a detailed range around diabetes and eye health that you might be interested in. And then finally, I thought I would mention the website Good Vision for Life. It is a website that is more public facing, but it has a lot of information there that you might find yourself of interest for when talking to patients, but that you might also want to redirect patient to. And that's all for me. So I think I've mentioned all the sites. We will share specific links to those sites with you after this event. And also I was going to ask Maria if you can think of any other websites or resources that I haven't mentioned. It was great to see KeepSight mentioned on your presentation. Thank you. And I think
I think that was really comprehensive. That was great. The other thing I would perhaps consider as well, and this should be the role of either the GP, optometrist, or ophthalmologist, is when patients are diagnosed with conditions like glaucoma or macular degeneration, to kind of look at the large patient advocacy groups and signing or getting the patient's consent to sign them up for things like either Glaucoma Australia or Macular Disease Foundation. Again, free and a lot of supportive resources for patients as well. But I mean, otherwise that was a great list. I actually had a question for you, Sarah. With the, you mentioned those information handouts that's available on the visioninitiative.org.au. Is that something that is an electronic resource that I could just like print off when I need it, or do I like get a physical copy, or how does that work?
So currently we do have a little bit of print stock if needed, but otherwise you're more than welcome to just go on the website, click on it, and then print a copy when you need it. Yeah.
Fantastic. That would be really useful. Thank you.
Beautiful. Thank you so much, Sarah.
You're welcome.
I'll just open up to everyone now for any questions. Belinda has had to duck off, but everyone else is still online. So if everyone wants to send their questions through, we'll get started on that. Oh, I do have one here for you, Paul. Was it an older demographic of patients who were identified in PenCap for that PDSA cycle?
Oh, I can't answer that question, unfortunately. I'll have to take that on notice. Sorry.
No, that's okay.
Belinda,
We can
Belinda ran the program.
I can get an answer.
Yeah, sorry about that.
No, that's all good. I'll follow that up and we can include that in the resource pack.
I'd almost certainly it is an older cohort, but I don't want to answer that.
That's good. There's another question here. Where can we find the other resources shown on the slide? Which website?
So if it was related to my presentations, after this event, we will share all the links that I've mentioned. And I'm guessing we can add the KeepSight as well. And then I've taken note of adding organizations such as the Macular Disease Foundation and Glaucoma Australia as well in it, which are excellent organizations. So thanks a lot, Maria.
No worries. Yeah. So I don't think I had any additional links. I think you already had the Optometry Australia link, which is the Find an Optometrist. There was a comment from someone in the audience as well that you could also search for things like optometrists that do home visits, optometrists who specialize in dementia-friendly eye care as well. So really you can get really specific or, as general as you like that search, but it's the same link that Sarah mentioned.
Thank you. We don't have any more questions at the moment, but I did notice that you were able to answer a few earlier, Maria. Was there any questions that came through that you thought might be helpful to share with everyone?
Yeah, there was a question about, I think there was a couple of questions about eye pads and eye patching. Someone asked about putting anesthetic in the eye. So usually with that, just warning the patient, it might sting a little bit when it goes in. Usually I just kind of get them to close their eyes and punctual occlude with a tissue for about 10 seconds. There's another question about using FML, which is a kind of a weaker surface steroid, and is there any scenario where that is okay to do? And it's really depends. I would say, with, as you guys are aware, using steroids for the eye can be really useful sometimes, but there are risks involved. And particularly if you're uncertain whether there is any infection involved, you have to be quite cautious, because using a steroid where there is infection could obviously make that infection worse. So it might be that they have a history of a certain condition where they have used a surface steroid in the past, where you feel more confident it's the same presentation. But I would kind of do it with a bit of caution and with some kind of safeguard of review, or then sending on to the optom or something like that. Or just, even if you think there might be a risk that the infection, if there is an infection, it'll get worse, let the patient know. If they do notice some discharge and things like that, then it suggests that they need to be reviewed more urgently or sooner.
Thank you. Oh, we did have a question come through as well, asking about what PenCat is. So I might just talk to that for a moment. So PenCat is a data aggregation tool that links to clinical software. So accredited or registered for accreditation practices all have access to this tool. So it can help identify different patient demographics in your clinical software, so a clinical software audit tool essentially. But if you do want to know more about PenCat, or if you're wanting to look at having access to that software, please reach out to Northwestern Melbourne Primary Health Network or your primary health network, and we can work with you on that.
I might ask a question, I guess, back to the audience, if they feel confident in kind of seeking eye care advice from whether that's primary eye care providers, so optometrists in their local area, or if they have kind of a friendly ophthalmologist that they feel comfortable reaching out, or is it something that people are a bit unsure when to do it and who to do it with? Like, what are people doing currently? And I guess it has this information changed, maybe the way they might do something like that. See if anything comes up in the
that's a great question. I'm interested to see or hear about those answers. So if anyone wants to type any responses in the chat or the Q&A box, I'm monitoring both, so I'll read them out. Nothing as of yet. Everyone
It's
might
okay,
be
all
shy,
good. Yeah,
bit
fair enough. It's pretty late as well. People have had long days probably.
Yeah. It's okay. If any other questions do pop up, feel free to pop them in the chat, and we can jump in and answer those. But I might go through our QI activities just before we wrap up. So hopefully you can see that slide. So as I mentioned earlier, when Belinda and Paul were speaking through their QI activities, a part of the iHealth QI project that was running this year, we looked at some of those QI activities developed by general practices and managed to turn those into resources that can be downloaded to help GPs do their own QI on iHealth. So there's 2 that'll be launching tonight, and they'll be included in the resource packs that get sent out post this webinar. So we've got one that's focused on increasing the number of people living with diabetes who have been referred to an optometrist. And then our other activity is focused on increasing the number of patients who have had preventative eye care screening. So there's a lot of QI activities under both of those, and it steps you through the PDSA cycles and really a qualitative approach to QI. So hopefully those will be helpful for everyone, but yeah, keep an eye out for those. But there's no more questions in the chat, so we might move towards wrapping up if that's okay with everyone. So I'll just let everyone know that we would really love to have your feedback on the session. So there's a QR code for you guys to scan and provide some feedback. That would be excellent. And so you will receive a post-session email within a week with all the resources and the links from Sarah and Maria and the QI activities. All of that will be included, so keep an eye out for that as well. And then there is the CPD hours for this webinar as well. And if you're interested in attending any of our other education sessions, please go to our website and have a look through about what's coming up in the next few months. But thank you everyone for attending, and thank you Sarah, Maria, Paul and Belinda for those amazing presentations as well. That was really helpful. So thank you.
Thank you for having us.
Have a good night.
Thanks everyone.